So there were many arms to the study. There was a placebo arm, there was a glucosamine-only arm, there was a chondroitin-only arm, there was a glucosamine plus plus chondroitin, and a celecoxib arm. And overall, they did not show that any of the glucosamines and sulfates were better than placebo. Placebo reduced pain and swelling by 20%, so did glucosamine and chondroitin. So they had a placebo effect, but there was a small subset of patients here. It was important to know that there's a subgroup of patients who had moderate to severe knee pain in whom the glucosamine-chondroitin combination worked better. So this was addressing clinical symptoms and clinical benefit. So there was some clinical benefit in a small subgroup of patients with glucosamine and chondroitin. A subsequent analysis from the same GATE study, it's an NIH-sponsored study. The effect of glucosamine, I'm not going to details of every study, I'm summarizing them for you. The effect of glucosamine and chondroitin on the structural progression of knee osteoarthritis. This is from the second report from the GATE trial, published in October 2008, did not show any reduction in joint space narrowing. There have been isolated reports. There have been some analysis outside of this which showed that maybe there was a reduction on MRI of knee space narrowing after glucosamine and chondroitin, but in this large trial, this has not been shown to proven. So there have been also some meta-analysis of glucosamine and chondroitin, which overall, there's some minor symptomatic benefit, but no structural benefit. The osteoarthritis, just like the EULAR and ACR recommendations, we have an osteoarthritis group, Osteoarthritis Research Society recommendations, 2010 February. They overall give you a strength of recommendation for each intervention. So they put oral anti-inflammatories as 93%, topical NSAIDs and scapsicine at 85%, and some other percentages. The strength of recommendations are in the strength of how strongly they recommend something is in parentheses. And you see that glucosamine and chondroitin can be used according to them for symptom benefit. It's a 63% strength benefit. This is somewhat lower even than knee guards for osteoarthritis of the knee. And for structure, if you're going to tell your patients that it's going to, prevent your knee from getting worse or improve the knee osteoarthritis, that's not recommended at all. The strength of recommendation is only 41%. So according to the Osteoarthritis Research Society recommendations, the only medical or pharmaceutical things which we should be prescribing to patients here, according to them, is anti-inflammatories and maybe paracetamol, but anti-inflammatories are number one on their recommendation. Now here too is hyaluron injections for symptomatic benefit, 64%. Again, a very low strength of recommendation. In my personal use, I've not found it to be very useful. This is a feeling for many rheumatologists that they don't find it to be extremely useful, even for symptom benefit, and there is no structural or disease-modifying capacity for the hyaluron injections. Intra-articular injection of steroid, though, had a much higher strength of recommendation, 78%. And this especially is more beneficial. If you have a patient with osteoarthritis with a knee effusion, it is much more beneficial that they get symptomatic benefits much more if injected a steroid rather than a hyaluronic acid. Other nutraceuticals, there was some benefit of, there was one small trial that shows that symptomatically curcumin is the active ingredient from turmeric is useful for patients with osteoarthritis. And then avocado, soya, saponifiables again offer some symptomatic benefit, but they are not disease-modifying drugs. Okay, let's go back in time. Doxycycline, this was an older study, about 5-6 years old. Doxycycline was quite exciting because we thought that it inhibited collagenase activity and nitrous oxide production in vitro. So Brandt reported a trial of 431 overweight women with unilateral osteoarthritis of the knees between 45 to 64 years old. There was a decrease in joint space by 30% at 30 months, but it did not improve pain or improve function. So you're giving the patient a drug, but it does not improve the pain or function. And surprisingly, it did not decrease joint space narrowing in the other unaffected knee. The unaffected knee stayed the same, which, okay, maybe in the affected knee there was more nitrous oxide and more collagenase activity, but the other knee was unaffected. So doxycycline sort of fell out of favor, and subsequent studies did not show us much of benefit. So again, it's not been classified or approved as a disease-modifying drug. There were many MMP, matrix metalloprotein inhibitors, which was a hot new thing for some time, where we were really excited about it, but it failed because MMP, though it showed some symptomatic benefits or structural benefits, there's a compound called matrix metalloprotease 1, which was released, and then it caused a horrible syndrome called musculoskeletal syndrome, where patients started getting nodules and developing decutrans contractures and extreme pain and flexion contractures, and so that was dropped. There are still trials of MMP13 going on, which does not cause the musculoskeletal syndrome. Not ready yet. This is another picture of one of our events. We have been able to attract people because you're all on the threshold of your great arthritis foundation, which I'm so excited about. We have attracted patients to our events by offering them free bone screening. Patients love this, and then they come, and then we educate patients about rheumatoid arthritis, what they should do. Right now I've been emailed about we're having a stress management workshop for our patients on how to manage stress through yoga, diet, exercise, breathing techniques, etc. Patients love these kind of things, and they come to these workshops, so we managed to attract them. And all of our events, the pharmaceutical companies sponsor it. They do not have any input into our agenda, and we don't mention the drugs. We don't let them to display any information about their products, but they do want to promote things. So, I would encourage you to ask them to sponsor your workshops. This first one is somewhat exciting. Lot of interest in risedronate. There were many trials of risedronate in arthritis and rheumatism in 2006. We saw that risedronate decreased these biochemical markers of cartilage degradation, but did not improve, and it improved the subchondral bone. Remember, we